Now we will begin session 2, Linking NTD Innovations with Health Systems for Pandemic Preparedness. For this session, I'd like to invite Dr. Aya Yajima from WHO Southeast Asia region, Dr. Charles Mowbray from Drugs for Neglected Diseases Initiative, Dr. Nobuo Saito from Institute of Tropical Medicine, Nagasaki University, and Dr. Masahiro Kajihara from International Institute for Zoonosis Control, Hokkaido University. Dr. Yukie Lloyd from the GHIT Fund will moderate the discussions. Yukie, the floor is yours.
Thank you, Naoto. I'm Yuki Lloyd from Investment Strategies Group from GHIT, and I will be the moderator for the second session of today titled Linking NTD Innovations with Health Systems for Pandemic Preparedness. So this is a small group. We have a small group today, but this will be a very unique session covering a wide range of diseases and topics from the present situations and innovations of NTDs on the ground to pandemic preparedness and how they interconnect from a health system standpoint. So the speakers will give presentations first, followed by a Q&A session where we will be taking some questions from the floor. And please allow me to introduce Dr. Aya Yajima from the WHO Southeast Asia region, the first speaker of this session. Unfortunately, Aya could not join in person today, but she has shared with us a video recording. Could we start the presentation?
Good morning, everyone. My name is Aya Yajima. I'm the Regional Advisor on Neglected Tropical Disease, or NTDs, in WHO Southeast Asia Regional Office. Today, I'd like to briefly talk about progress and remaining gaps in eliminating and controlling NTDs in the WHO Southeast Asia region and its importance of linking NTDs intervention with health system. We have 11 member states in the WHO Southeast Asia region, and we have a regional office in Delhi in India. Out of 21 disease conditions that are prioritized as NTDs, our region has 16 NTDs as highlighted here, with at least one of them endemic in each of the 11 member states. Our region, because of many countries with large populations, account for more than half of global burden of NTDs in the world. Therefore, eliminating NTDs in the WHO Southeast Asia region is considered as a global priority, and for this reason, eliminating NTD was made as a regional flagship priority in the region since 2014, and a remarkable progress has been made. The number of people requiring interventions for NTDs reduced by 29% in the last decade. Many public health achievements in terms of communicable disease elimination has been achieved. And among NTD alone, 10 disease elimination has been achieved so far, as highlighted in yellow. Unfortunately, I cannot talk about every one of 16 NTDs burden and progress in 10 minutes presentation today. So I'd like to highlight just a few, and I'm happy to have other occasions to talk about more details if there are any interest. Today, I'd like to share elimination of visceral leishmaniasis, or VL, in the region as an excellent example of success story of research and innovation. VL, also known as Karaza in our region, is a life-threatening disease that affects the internal organs, particularly the spleen and liver, and fatal if untreated. It's caused by the bite of female sandfly carrying the leishmania parasites. Its elimination as a public health problem in the Southeast Asia region is one of the global targets in the NTD roadmap, and it has a tremendous progress in the last 10 or so years. The number of new reported cases has reduced by 98%. Last year, Bangladesh became the first country in the world to be validated by WHO for having eliminated VL as a public health problem. All endemic blocks of India also achieved the elimination target of 1 case per 10,000 population last year, and within the region, only 2 districts in Nepal is yet to achieve the set target as shown in the right graph. This success is due to the fact that VL elimination in the Southeast Asia region evolved with rapid progress in R&D, particularly development and validation of new treatments and diagnostics, and its operationalization for programmatic use in countries. This is a very busy slide, And I'm not going to go into every detail, but just want to highlight that those highlighted in blue color indicate CRO's, WHO CRO's initiative to date to enhance and sustain political momentum, whereas those in red are technical guidance and recommendations released by WHO headquarters. Those highlighted in orange indicates key efforts of national programs adopting global and regional guidance. As you can see by colors, as soon as new tools are developed and evaluated, WHO organized global or regional technical advisory group meetings to discuss and endorse new tools and strategies, which was quickly adopted by the national program in endemic countries, and the implementation was scaled up, because the WHO meetings always involved the government authorities. So this rapid translation of science into policies and practices in national program was made possible by continuous high-level advocacy by WHO at the regional level as well as the global level, leading to strong government commitment and leadership, and also a strong support and collaboration of donors and research partners for the national program. However, we have remaining and emerging challenges to move this fight forward. A certain proportion of VL cases that have apparently cured is known to relapse after initial cure, as you can see on the left upper side graph. But we are yet to have a clear WHO recommendations on treatment of relapse, which is currently being debated at the guideline development group. One challenge for VL, as many other NTD, is that there are limited data from high-quality clinical trial, which makes WHO come up with a clear recommendations very difficult. Also, as you can see on the left lower graph, 5 to 15% of cured VL cases are known to develop something called post-Kaiser dermaleishmaniasis or PKDL, and they are believed to serve as a reservoir of VL transmission. Therefore, WHO targets include detecting and treating all PKDL cases. However, it is complex to estimate how many PKDL we should expect each year because it depends on various factors such as treatment regimen, patient's immune response, and even concurrent infection, because in endemic areas, it is very common that the patients are infected with multiple NTDs or other communicable diseases. We also don't have a point-of-care diagnostics for PKDL and test of cure. We also still lack effective treatment of PKDL as relapse and HIV-VL co-infections. For those reasons, even countries that achieve validation or elimination of VL as a public health problem need to sustain strong surveillance on the ground to detect and treat early the PKDL and VL cases. However, as the number of cases go down, it is becoming more and more difficult to sustain universal access to drugs and RTTs, and also to sustain capacity for continuing effective active case detection and vector control, because donor funding is reducing. We are also seeing a potential impact of climate change already, because distribution of sandfly is expanding, for example, to highland in Nepal, and as a result, we are also seeing expansion of VL cases to formerly non-endemic areas. To sustain and achieve interaction transmission, we need to also address social and environmental determinants of health, particularly housing conditions that favor sandfly breeding. I'd also like to briefly talk about dengue, which is most popular NTD, yet continue to be neglected by donors, global donors for prevention control efforts. Our region is among the highest burden region for dengue in the world, although since last year, American region report the highest number of cases, and the cases in African region has also increased significantly. And due to this expansion of dengue, WHO graded global dengue situation as multi-region grade 3 public health emergency last year. In our region, as you can see in this graph, we had large-scale outbreaks in number of countries last year, particularly Bangladesh. And we intensified our country's support. By the way, you can also see the impacts of COVID-19 pandemic on the reported number of dengue cases in 2022 and 2021, which has now well recovered. Similar trend is seen in many other entities. The key strategic interventions of National Dengue Control Program to prevent and control dengue transmissions are surveillance and data analytics, vector controls, case management, and public awareness. But you may realize that in order to deliver these interventions effectively, we need to strengthen healthcare workforce capacity on case management, laboratory and vector control, strengthen surveillance systems, improve health literacy and knowledge in communities, and enhance multi-sector collaboration. In every key aspect, we intensified country support in the last few years, for example, by establishing monthly reporting mechanism and regional dengue dashboard at the WHO CRO, also launching an open WHO e-module on dengue case management in the Southeast Asia region, organizing multiple trainings on case management and vector control, and also facilitating interministerial cooperation through workshops at the country level. Yet, there remains multiple gaps, and you would realize that the majority of the challenges that we are facing on the ground is health system gaps and social and environmental determinants of health, including a lack of sustainable financing. Dengue is actually a great example. We tend to receive attention and also funds only when a large outbreak happens. But once outbreak subsides, everyone forgets. Very limited investment remain on preparedness or prevention of next outbreaks. The policymakers and even the public forget until the next outbreak unless someone continue to push. Every NTD or communicable disease elimination, national programs focus is to deliver relevant strategic services and public health interventions to affected communities through a primary health care. So we develop together with the national programs, a guideline, SOP, or tools and conduct training for clinical care, surveillance indicators, or mass workers administration, etc. for each NTD, so that the most effective evidence-based interventions to achieve disease elimination can be delivered by all countries in a similar manner. But to effectively deliver such interventions and health services, the majority of challenges and gaps we face is actually the health systems gaps. This include lack of sustainable financing or health workforce capacity, lack of health information system capacity, lack of medicines or other tools and functioning governance mechanism. And in order to sustain the impact of service delivery, it is also essential to address social and environmental determinants of health at the same time. For instance, addressing poor health literacy in communities, or improving community hygiene, or anticipating climate change impact. So in the WHO CRO, we are working on a new initiative called People-Centered Multi-Disease Elimination Approach, where we promote an integrated, sustainable, and holistic approach to accelerate elimination of multiple communicable diseases. We have seen a good example from the fight against COVID-19. Significant investment was made not only in the vaccine development, but also in building its regulatory and delivery system, health workforce capacity, health information system, and also community mobilization, such as social distancing. Everyone joined forces to achieve the common goal of control of the COVID-19 transmission. For other NTD too, we need to break silos and first integrate delivery of common or similar interventions and health services among multiple diseases if possible, then also address health system strengthening and social and environmental determinants of health together by involving those who are working on this area with those who are focusing on disease elimination. And importantly, we need also R&D and innovation in both areas. And this holistic and integrated approach is only possible when the government at the highest level takes a leadership. Finally, I'd like to mention that when WHO published the Global Entity Roadmap in 2020, it included a gap assessment in different aspects of the entity program. And recently, a new gap assessment was also done on 4 dimensions focusing on M&E and research gap to compare the progress between 2003 and 2019. The report is soon available for publication, so I'd like to invite anyone interested in referring to the report to see where the remaining gaps are and work together to fill the remaining gaps. Thank you very much for your attention and also this opportunity, and please feel free to write to me if you have any questions or need any further information. Thank you very much again.
Okay, we would like to thank Aya for the video message and the very informative overview to start this session with an example of progress and challenges in eliminating VL and dengue, and also she touched on some remaining gaps. So we understand that a holistic and integrated approach, and especially in R&D and innovation, is still required on the field. Okay, with that, I would like to move on to our next speaker. Our next speaker will be Dr. Charles Mowbray from DNDi. He will be covering the needs on the ground to combat NTDs, with a focus on the needs for therapeutics and progress in the field. Okay, Charlie, it would be great if you could start your presentation and keep it within 10 minutes.
Thank you very much. Thank you for the kind introduction. Good morning, everybody. Charlie Mowbray, the Discovery Director at DNDi in Geneva. It's a really great privilege and an opportunity to be here and to talk today about neglected tropical diseases, but also neglected patients, and our work on epidemic and pandemic diseases and how these are connected. At DNDi, we're a product development partnership. We seek to develop new treatments for the patients neglected by the traditional incentive model. That means that pharmaceutical companies often lack motivation and financial return to develop new treatments for these patients. So we're connected closely to the needs of our patients, and we work with them and with the healthcare systems and researchers in the countries in which they live, really with a focus on developing new treatments. And we do this through several different linked activities. So this is research and development, through inclusive partnerships, working with partners around the globe, strengthening capacity in the countries where the diseases are an issue, and advocating for changes in policy to develop a more sustainable ecosystem and to ensure that we have equitable access to new treatments that are developed. And that's our goal. It's the new treatments, it's sharing the knowledge, working openly, and engaging both private and critically public leaders to work together to come up with new solutions. This should help our patients, new treatments, better control and elimination of diseases, better health for the neglected populations, often the most poor, impoverished people living in neglected areas affected by multiple disadvantages of economics, of climate, of natural disasters, warfare and unrest. So they really need our help. We can also contribute to universal health coverage, and critically, our work here is as a model, an example of a new model for R&D, trying to make a more equitable R&D ecosystem. We work on many diseases at DNDi, indeed I think 11 today. I'm not going to go into the details of all of them, we've just been hearing nicely about some of them. I think the voices of our patients and those living with our patients speak more eloquently than I can. But for a disease such as Chagas disease, it must be really frightening to know that you've been infected with an infectious disease for which there is only a limited or no treatment that's unlikely, not necessarily going to cure you and may bring serious side effects. So for us to help those patients and those populations to have renewed hope by bringing new, improved treatments that can really deliver a significant improvement in the standard of care is our goal. Chagas disease is a WHO-listed neglected tropical disease, as is dengue. We've just been hearing about dengue, and the increasing burden of disease fueled by the changing climate, the migration of mosquitoes, also the change in populations, moving populations, has seen this year staggering numbers of new cases of dengue, and in areas that weren't previously endemic. This is exposing populations who've not been previously exposed to dengue, who lack natural immunity and are suffering often more severe disease. So not only large numbers of cases, but also an increased severity of disease and more patients being admitted to hospital and overwhelming the local healthcare system, very much like the COVID situation. So it's not just dengue, but it's the impact on the healthcare system and its ability to cope and look after its patients. We really need to develop new treatments to stem the tide and reduce the burden on the healthcare system. At DNDi, we responded during COVID, as many people did, pivoting our model to try and help particularly our patients neglected by some of the new inventions that were coming along during the pandemic. And our work continues. We recognise the need to develop new treatments for pandemic preparedness. There are many viral families that pose a threat for epidemic or pandemic emerging and re-emerging diseases, and indeed new virus X type outbreaks. It's a huge task because there are so many families, and very few viral families have new treatments available or even in the pipeline. We talk about a landscape, but I would characterize it often as a desert. There's so little available. So we really need to develop new drugs and to develop them and have them ready so that they could be tested in an outbreak or in a new pandemic. These should be drugs that have been tested in preclinical systems, shown to be effective, and have some promise of helping with a viral infection, but critically also safe, preclinically and ideally de-risked in early human studies, phase 1 safety and pharmacokinetic studies, and also have the characteristics that should allow for fast, effective development and manufacture. We're working with a group of organisations that share our view that this is a critical need for the globe, and that by working together we have more chance of moving this agenda forward. And we've recently published our vision of what a therapeutics development coalition could look like and what it could do, and we really welcome further support and partners engaging in this work. We outline in this slide what some of the key activities of this therapeutics development coalition could look like. The first priority, we think, is really discovering new antivirals, aligning what we do with the needs that have been identified by the WHO in its blueprint, and starting to build a pipeline through partnership and developing new projects to move those drug candidates forward. At the same time, we need to prepare the clinical development pathway, developing and agreeing trials for conducting testing of new antivirals, and engaging with the regulatory agencies so that fast and efficient approvals can be ensured, especially during an emergency situation. And finally, if we're successful with a new treatment, we need to make sure that it's going to be made available. So working on early agreements by design to ensure that we have the right licensing in place so that everybody can get access to new treatments, not just those who can pay or those who live in high-income countries. We also need to have a strong manufacturing base and really to address all of the issues of access. We do this through working with partners around the globe. DNDi has more than 200 partners in 50 countries, in more than 50 countries. This is public and private, so universities, pharmaceutical companies, working with networks, especially in disease endemic countries, generating partnerships and working on access. And also, although our focus is on therapeutics, working with organisations that can develop, as we've heard today, the all-important diagnostics to bring the maximum impact. Together with our partners, we've built, I think, quite an exciting portfolio of products for these diseases. And I take the opportunity of being in Japan this week to highlight the critical role of our Japanese partners, the support of the GHIT Fund, and you can see what a significant portion of our portfolio depends on these critical partnerships. So we really welcome these, look forward to more Japanese partners engaging and announcing some new partnerships in the near future. I close just by identifying that we work on neglected diseases with a lack of knowledge. So we have scientific gaps, we have gaps in the discovery and development pipeline, and we have a lot of work to do. I won't go into all of these in detail, but I think you can see there are challenges here around designing different types of drug, biomarkers, looking at how we combine drugs and how we move those and test those new innovations and inventions forward in an efficient way. There's many opportunities here for us to develop new antiparasitic, antiviral, antifungal drugs, but also to look at the host pathogen interface and think about host-directed therapies, controlling the immune system or harnessing the immune system to tackle infection, and thinking about also dampening the immune reaction down to limit the pathology in some diseases. So lots of scientific opportunity and bringing new compounds, drug candidates, test systems and models, and different technologies and sciences. Particularly, we've heard already this morning in Japan, there's a great wealth of innovation and new approaches, artificial intelligence and other technologies that could help us to do this work more efficiently and more successfully. So we congratulate the partners that are working with us today and thank them and welcome new partners joining us, and I'd be very happy to talk to anybody who'd like to help us tackle some of these big challenges. Thank you very much.
Okay, thank you, Charlie, for highlighting the critical work our DPs are doing on the ground and also touching briefly on pandemic preparedness, what you do for pandemic preparedness. So you emphasize that there is so much more to do in R&D, which I think we all got the message. Okay, the next speaker will be Dr. Nobuo Saito of Nagasaki University. He will be joining online. He will be covering the existing needs on NTDs with a special focus on rabies on the ground and also the challenges he has faced in bringing products to the field. Nobu, it will be great if you could share your screen, which you already have, and start your presentation. Please keep it within 10 minutes. The floor is yours.
Thank you. Can you hear?
Yes, we can hear you very well.
Thank you. Good morning, everybody. I'm Nobu Saito from Nagasaki University. I'm speaking from Kenya today. Briefly, I want to explain my background. I'm an ID doctor, and I've been conducting research in tropical medicine in low middle income country where I have stayed for more than 10 years. My background in Japan, I have been involved in vaccine effectiveness study of influenza COVID-19, and in the Philippines, I established research laboratory at major infectious disease hospital in 2014, where I conducted several clinical research on diphtheria, leptospirosis, and dengue. Since 2018, today's topic, I have also been engaged in rabies control project in the Philippines too. Since 2023, I have been in Kenya conducting clinical study on tuberculosis. Additionally, I'm continuing rabies research in the Philippines and plan to expand my rabies research Kenya and Zambia in near future. So today I would like to share my experience and insight from working at grassroots level in low middle income country. I would like to highlight how grassroots level and field research are essential in driving innovation to combat neglected tropical diseases. I'm going to explain our rabies research in the Philippines too. So rabies diagnosis in human and animal is very complicated. Therefore, in many low middle income countries in endemic area, most rabies cases are not diagnosed. So to address this issue, we introduced rapid diagnosis test kit to the Philippines, which was developed by Oita University and a Japanese pharmaceutical company, Adotex. So this enabled rabies diagnosis to be performed anywhere else, and it significantly improved the surveillance capacity. We also developed the app in collaboration with Philippine Department of Agriculture to quickly share information about rabies outbreak in animal. With app, local veterinarian can input the data immediately after the diagnosis rabies using rapid diagnosis kits. The app automatically generates alert about rabies case, notify where and when and what type of animal are detected. This information is shared with rabies coordinator and also people living around this area too. I think its visualization is very important these days. So this application displays rabies outbreak and location on the map automatically. Also, this is really important. The system lets policymakers easily to know the situation visually and understand how serious problems are there. I believe this is important. It can change decision-making to secure necessary budget too. So our rabies control strategy involved using rapid diagnosis test kit to quickly detect rabies animal anywhere else and share the information through the application and implementing the rapid response measure based on One Health approach. The goal is to eliminate rabies from the community as quickly as possible, and this method has been documented and published as rabies rapid response toolkit manual. These methods were not well developed from the beginning. Actually, we developed in the field and it took more than 3 years. So these methods were not developed from the beginning, and we first tested them in real world setting where there are many rabies cases there. And we made a lot of improvement. And after that, we conduct evaluation study and introduce our method to pilot area. We continue making further improvement based on the field experience, and then eventually we develop practical and effective methods. Finally, this approach has been scaled up nationally, as you can see the map. And now this method has been implemented in more than half of the region in the Philippines. So, as a researcher and academia working in the field of NTD in overseas setting, we see our role is here. So, in GHIT development process, we believe that before product is finalized and fixed, more exploratory study is needed. These studies should be continued in real-world setting and utilize many real samples. And also, the study should incorporate feedback from field practitioner and local researcher to improve product further. As I mentioned earlier, our initial rapid diagnosis test kit was not practical or usable in the field too. Here you can see original product and its manual. These methods were completely unsuitable for implementation in the field setting first. Therefore, we made many improvements through field trial and discussion with field practitioner and local researcher. We could do this trial because there are many samples there and good collaborators. Here are the key factors that contribute to the success of our improvement. First, we had excellent collaborators in the field. Their expertise, their insight were necessary and crucial for the improvement. Second, we were able to access a lot of rabies samples. This allowed us conduct a lot of kind of trial and evaluation. Finally, we are able to conduct extensive testing through try and error approach, which help us improve our method based on real-world feedback and feedback too. I also want to explain why our method was smoothly adapted in the Philippine government too. As you can see, this figure shows rabies case map from our data share system. I took this data just last week, and our project officially ended 2023, so more than 1 year ago, but it has been continuously implemented by Philippine Department of Agriculture. As you can see, there are many red dots here in case map. Red dots indicate rabies case detected in 2014 after our project was finished. So more cases were detected actually by local veterinarian after our project was finished. From the perspective of sustainability, this is actually really great outcome for us. So what made our method adapted and continuously used? So developing diagnosis method and application may be relatively easy, but their application, implementation and sustainability are extremely challenging. In our project, we started from really scratch and we developed it together from the scratch. At first, we brought very rough idea to Department of Agriculture. At that time, people laugh a lot and did not take seriously. However, after visiting many times and having a lot of discussion, we gradually built a relationship and they became motivated to work with the idea. Their active involvement in developing a system was really key for the successful. Additionally, from the beginning, the system was designed to integrate it into existing IT system in Philippine Department of Agriculture. So this made it easy to smooth join the national system after we developed the system. Moreover, we repeatedly improved the system based on field trial and their feedback. This made the system more user-friendly and practical. These improvements were able to ensure its sustainability. One important caution when conducting clinical study in NTD endemic country is the difficulty obtaining IR approval sometimes. In some cases, this process can be extremely challenging and take a long time. For my experience, one simple observational study took more than 1 year to get approval. It was so terrific. To avoid such delay, it is highly recommended to carefully select a counterpart institution and collaboration in target area too. So for innovation in NTD, I believe more exploratory research is needed in NTD endemic area too. Effective collaboration and reliable partner are essential to achieving meaningful progress. There are researchers, myself, and Dr. like Kajiwara, who have spent many years working in field setting overseas. Through the GHIT framework, there are Japanese network of researchers conducting study abroad. These researchers know the local situation very well and have a very good collaborator. So please feel free to utilize academia like us. We are very open to provide help and collaboration too. Thank you very much.
Okay, thank you, Nobu, for your presentation. We had a lot of take-home messages, but rapid detection, data sharing, and also visualization is important for monitoring and obviously decision-making as well. And these barriers you have experienced firsthand are very important information to consider when we move forward with product development. And also mentioned in session 1 as well, the speakers mentioned that the key to success is really collaboration at an early stage. Okay, with that, our next speaker will be Dr. Masahiro Kajihara of Hokkaido University, who will be speaking about the role of health systems to prevent and prepare for potential pandemics and some exciting work that he does on the ground for pandemic preparedness. So Kaji, it would be great if you could start your presentation and please keep it within 10 minutes. The floor is yours.
Thank you very much for your kind introduction. I'm really honored to be participating in this important forum, and glad to have an opportunity to introduce my very basic study in Africa in the context of pandemic preparedness. So this map shows the distribution of the zoonotic infections emerged recently. All of them are caused by the viral infections. So as exemplified COVID-19, the emerging infectious diseases can provide a great impact in the global public health. So there is no doubt in future we will have a next pandemic. So even academia, we have to start the preparedness study for as soon as possible. Somebody calculated that 60% of emerging infectious diseases are actually zoonotic diseases, and 75% of them are the viral infections. So considering this fact, the pathogen X causing the next pandemic may be animal viruses in nature. So this is a mechanism behind the emerging infectious diseases. So wildlife in nature have a variety of viruses, not only viruses, microbes. Some of them can directly or through the intermediate hosts like domestic animals or vectors, and then transmit to humans. And then at some moments we will recognize as the emergence of the infectious diseases. My research goal is to prevent this kind of transmission from nature to humans before transmission actually. So to do that, I'm doing the pathogen discoveries and to understand the genetic diversity of the viruses, and then also the known pathogens. We need to understand that ecology and characteristics of the viruses to prevent transmission and do the risk analysis. And some viruses can be bottom-up, the science field, as a bioresourcing. So especially I'm really interested in the bats because they host a remarkable diversity of viruses. So far, 33 virus families have been reported from the bats, including zoonotic pathogens. So it is a possible scenario, again, that some virus with a potential pathogenicity can cause the next pandemic. So I'd like to talk about my representative, some outcomes of our research, the Marburg virus study. So Marburg virus disease is one of the priority disease, and together with Ebola virus, belonging to the family Filoviridae, and it causes these hemorrhagic fevers. And importantly, there is no effective prophylactics and therapeutics yet. So this map shows the countries affected by Marburg virus disease so far. Important fact is after 2021, we have at least one outbreaks every year in some African countries. The ecology of the Marburg virus have been the mystery so long time after the appearance of the virus. However, recent studies demonstrated Egyptian fruit bats, this is a widely distributed in Africa bat species, are the natural reservoir of the virus. Actually, we also contributed by proving the presence of the Marburg virus in Zambia. We have some satellite laboratory in Zambia, and then we are conducting some field activity for the Egyptian fruits bat study. This is a cave in the located near from the Lusaka, capital city of Zambia. We capture the bats here. And the serological screening demonstrated remarkably high seroprevalence for the antibodies against Marburg viruses. And also we found serological peaks every November and December. And after 5 years from starting this project, finally we detected more direct evidence of the presence of Marburg virus. We detected some positive bats in September and October. So far, we have continued the 10 years activity in Zambia, and then we found the ecological dynamics of the virus infection. So in September, virus is actively infect to the bats. As a result, repeated the elevation of the seroprevalence were observed in November, December. So this fact indicates the spillover risk is high around September in Zambia. We also conducted phylogenetic analysis, and at least we found that 2 different lineages of the viruses have been circulating in Zambia case. One is cross-related to Uganda and DR Congo outbreak strains, and the other is related to the outbreak in Zimbabwe. So now that findings arise in some questions about Marburg virus ecology. Actually, there are a long distance between Zambia and Congo and Zimbabwe. So how these viruses are migrating this or transmit for this long distance. However, to answer this question, our limited understanding of the bat's ecology hinders a holistic grasp of Marburg virus ecology. So now our team are trying to understand the virus ecology by understanding the host ecology, by employing the biologging approach. So this approach is to analyze the behavior of the animals by the data loggers communicating with satellites. So we are now tracking the movement of the virus from the space. So this picture shows the bats with data logger. So after attaching the data logger in the field, we start to track the bat movement in the night. So this is an animation. Individual triangle indicates the individual bats tracked by this study. And after actually sunset, they start to come out from the cave and then look for the food outside of the cave, and then coming back to the cave before the sunrise. And maybe you may find the cave there at the middle of the map, but you can find some triangle come out from the eastern part from the cave. So I'm sorry, we have a day 7, but I'd like to move forward. Then we found unknown caves are there in eastern mountain area, which means expanded risk areas. And then surprisingly, we found hundreds kilometer flights per night, even per night. And some bats are actually enter into the highly populated areas. And also we found the transboundary activities from Zambia to Zimbabwe as well. We also found a seasonal difference in the bat movements. In October, when the Marburg virus positive bat was found, they do not fly so long compared to April, but they tend to find diet near the residential areas, which means increased risk of the contact with bats and humans. So the Zambia has never had an outbreak. However, I have to say, unfortunately, risk of Marburg virus disease seems increasing. One reason is growing population in Lusaka. It is reaching to the cave areas. And the other is the bats in the cave draw the public attention. If you go to YouTube, you can find a lot of videos that tourists enter into the same cave without wearing any protective equipment. Now we started the serological screening with the authority of Zambia. So I do not have enough time today to comprehensively introduce my research activities, but not only pathogenic viruses, unknown novel viruses have been also detected from the bats in the same cave. which means the cave provides a suitable situation for the pathogen spillover. So not only in the fieldwork, I'd like to introduce the development of rapid diagnostic kits for Ebola virus disease in our institutes. So this is a collaboration with Denka company. So these kits can give the result in 20 minutes and without no equipment, special equipment, and we can store them at room temperature for several years, and it is suitable for the rural areas. Actually, this kit has been already approved by the PMDA in Japan, as well as Ministry of Health of DR Congo. And actually, that kit has been used in the Ebola virus disease control in Congo. So finally, I'd like to mention about my research interest again. We are trying to prevent the transmission of the virus from the nature to humans. And then by using the kits, we try to detect the outbreak as soon as possible, even emergence. Thank you for your kind attention.
Okay, thank you, Kaji, for the very exciting and visual presentation. We learned that the importance of categorizing the phylogenetic diversity of viruses and also ecological dynamics of the viruses is very important. And I'm sure that a lot of people in this crowd are very curious how you catch these bats, but that will be for another session. Okay, thank you so much to all the speakers. Now I would like to move on to the Q&A session. I have prepared a question to the speakers. Since we have one person online, I would like to ask one question to the speakers, and we're kind of running short of time as well. And also after that, I would like to ask the floor for any additional questions. And in this sessions, I would like the speakers to provide their insight on the following question. So from your experience, how has the COVID pandemic, I know Aya has mentioned already in her recording, but how has the pandemic affected the NTD programs on the ground? And also, what can we apply from pandemic preparedness or from the COVID experience? What can we apply to existing programs? And vice versa, what sort of existing programs or some health system we can use to prevent future pandemics or to use for pandemic preparedness? And can we start with you, Charlie?
Yeah, thank you. It's an interesting question, important for us. So obviously the COVID pandemic had an impact on our activities, our clinical trials, and it caused some delays and changes in how we were working. But I think it also highlighted some things that we've recognized from neglected diseases for many years, that innovation doesn't reach all patients at the same speed. And so we recognized we could contribute in this space in a number of ways. First, in the policy advocacy space, development of new treatments, new technologies really needs to be done with the mindset of equitable access by design and not as an afterthought, and not waiting for licensing too late. And we saw significant delays in rollout of diagnostics, vaccines, treatments for those reasons. So bringing our experience of trying to develop medicines where there isn't a commercial incentive, we felt we could contribute to that dialogue on the policy level. We also found that we could pivot our network and our expertise in drug discovery and science to support the evaluation of new treatment options and arms for clinical trials. And we helped to set up a Pan-African clinical trial platform called ANTICOV, which is now turned into a clinical trial platform called Panther as a new organization. And we found that we could contribute in that space and continue to learn some lessons. And today, we're drawing on that experience in our dengue program. We're working with partners in endemic regions and really trying to apply the lessons about selection of antivirals and how to test those, benefiting from that experience. We've also been exposed to new technologies, as everybody has, new science, new partnerships through our work on COVID. And this has also allowed us to start to introduce some of these new techniques and partnerships into our NTD work. So I think it's been a virtuous cycle. Thank you.
Great, thank you. Nobu, do you have any comments on this?
Thank you very much, sir. I would like to share the situation of rabies in the Philippines. Actually, after the pandemic, getting worse very, very much. In the Philippines, COVID pandemic greatly worsened the rabies situation. Rabies-related deaths nearly double compared to before the pandemic, actually. The Philippines had one of the longest lockdown in the world. During this time, mass dog vaccination completely suspended after for almost 2 years. And then vaccination coverage in the dog almost became zero. And there many people died due to rabies. And also during the lockdown, many people bitten by dog, they were not able to go to a medical facility. And then they couldn't get a PEP, post-exposure prophylaxis. When I work in the hospital, I saw many rabies patients who die because they couldn't go to the animal biotreatment, the health facility, because they are closed or they are not allowed to go outside. It's really terrible situation. As lesson learned, I believe that even during the pandemic, essential preventive measures such as childhood vaccination and rabies vaccination for human and animal should be maintained. While activity may be need to be scaled down, but it is crucial to set priorities to ensure continuous prevention measures such as mass vaccination in low middle income country. So mass vaccination of a dog and administration on post-exposure prophylaxis and animal biotreatment center should continue even during the pandemic situation. That is my opinion. Thank you very much.
Thank you, Nobu. And Kaji?
Thank you very much. So our institute have, I told we have a satellite laboratory in Zambia. We have a 40 years collaboration with University of Zambia. So before pandemic, actually, we have a collaboration, but finally, because of the presence of our university, the collaborator in Zambia tend to rely on us some technical issues or some knowledge levels. But when COVID pandemic occurred, we had to evacuate from Zambia. We couldn't stay there. So at that moment, I think our counterparts, the independence mindset, is grown very, very big. So actually, some newspaper article said that they are doubting that Zambia can do some detection of the viruses or the sequencing of the COVID-19. However, actually our counterparts did it by themselves without any, we also actually did some advice, but they managed by themselves. So similar situation occurred recently. Actually, they have imported dengue cases, but immediately they did the diagnosis of the dengue and then report it with a sequence. So actually at the local level, it is quite important to be able to diagnose some outbreak or the cases of infectious diseases. So in terms of that, the capacity level of the local capacity level for the analysis, especially the sequence analysis equipment and skill level are actually pushed up by after the COVID-19, I think.
Great, thank you so much. So we do see some unexpected positive outcomes in terms of capacity building, but at the same time, for people who are in the R&D, the impact of pandemics is something that we should keep in mind. Thank you so much for your insight. And now I would like to ask the floor for any questions to the speakers. And I believe we only have probably 5 minutes, so we can take 1 or 2 questions. Please make sure to mention whom you'd like to address your question to, and please state your name and affiliation. If you could raise your hand, as with session 1, our staff will bring you the mic. Does anybody have any questions? Yes, please.
Sorry, if no question, I have to ask. Okay, one question to Aya, Yajima-san, and the other one is Hajihara-san. Okay, first question is regarding that you didn't mention, Yajima-san, you didn't mention that kind of schistosomiasis in this area. Because GHIT really supported that pediatric form of praziquantel for preschool children. So what is kind of demand and what is your strategy for this one? To Dr. Kajihara, actually there are kind of rare cases for universities to develop that DENKA with DENKA that it is kind of into the market. Actually, I know that a lot of the JICA project and etc. But they had a quite good research, but not a real kind of product in the market. So roughly how many this DENKA, that quick Navi kind of produced and used in DRC and in other places, and what kind of a challenge of getting that in the market?
Okay, so Sam, your question to Aya, I will convey your question as she just provided the recording. But Kaji, would you please answer the question?
Okay, thank you very much. For the DENKA company, so far we have provided, I think more than maybe less than 10,000, but several thousands of the kits already to the DR Congo. But actually it is before the approval of the PMDA and also the Minister of Health of the Democratic Republic of the Congo. As a research tool, we started that kind of collaboration. So after the approval, I think that not so many kits have been dispatched as the products, unfortunately. The one reason is that the case of the Ebola virus disease are not huge compared to other diseases like malaria or TB. Yeah. So that is one challenge, how even though we could make a good product to commercialize I think there is a big challenge. So if you have some good ideas or suggestions, I'm really glad to hear that kind of suggestions. Thank you very much.
Okay, thank you. I think we have another question. Thank you.
Hello, Peter Warner at the Gates Foundation. Probably a question for Dr. Kajihara. Very interesting presentation. I guess one of the questions that's been on our mind since COVID is, what is the most likely class of viruses that's going to cause the next global pandemic on the scale of COVID? So I wonder whether you have any thoughts on that. Do you think it's going to be similar to the COVID from the coronaviruses, or is it going to be a paramyxovirus virus, or what do you think?
Thank you very much. So actually, thank you very much for saying the interesting to talk at first. I think I'm very glad. And then regarding to your question, it's a really a difficult question. Actually, I had some discussion yesterday with the specialists from CEPI as well. But personally, there is some algorithm to make the scores of the potential pandemic. I think some researchers already tried and then open for websites. But personally, I'm thinking among the many viruses, especially possessed by the bats. As you mentioned, the corona could be the one of the candidates, and also I think the paramyxo is one of the candidates. I don't know how many people pay attention to the paramyx viruses, but considering the pathogens belonging to the paramyx viruses, there are so many pathogens for humans and animals as well. And unfortunately, the bats have a very wide range of the diversity, the genetic diversity of the paramyx viruses. And we actually, I don't have the time to explain, but we already detected some viruses which is really close, genetically close to the known pathogens, but new. So I'm thinking that such kind of viruses sharing some common feature with the known pathogens could be, I think, the candidates for the next pandemic. Personally, I'm thinking. So I'm doing the more deeper study among the viruses I found. I hope I understand.
Thank you, Andrew. If I could just respond. I think that's That's certainly something which we believe as well, with some of them being respiratory and therefore easily transmitted. And maybe that's a very neglected area of research to research those types of viruses, and perhaps that's something that we should put more effort into going forwards.
Yeah, thank you very much for adding the important keywords, the respiratory transmission. I think it is also important features to make global pandemic. Yeah.
Okay, thank you for the exciting interaction. Unfortunately, I need to close this session. Thank you again to Aya, Charlie, Nobu, and Kaji for the very interesting presentation and for the discussions. And thank you to the floor for your valuable questions.
GHIT Fund. Fight neglected diseases through partnerships.